Good morning, everyone, and delighted to be here talking about antimicrobial stewardship and, in particular, antibiotic durations, and particularly around the course length of antibiotics that we use to treat patients with sepsis. So, so why treat or why even look at antibiotic durations? If we consider patients with sepsis, who the vast majority of those patients looked after in a critical care setting. So in critical care, considering the wide hospital, it's a very small part of the hospital, but the antimicrobial use per patient far exceeds any other part of the hospital. So this table, the laser doesn't work so well in the light, but the table that's on your left is antibiotic usage data from UKHSA, and the unit of measurement is defined daily doses. I won't explain what that is, but really just to highlight that intensive care has 55 defined daily doses per admission, versus the next highest, which is 7. So it far exceeds anywhere in the hospital. And in patients with sepsis who are critically ill, the pressure to start antimicrobials is so strong that it's very difficult to influence the initiation of antibiotics. But the duration of antibiotics that are required is really unknown. And if we can optimize that duration, there is the potential to reduce the overall burden of antimicrobial use. So antibiotics are a driver for antimicrobial resistance, which you will all know, but that is often viewed as a societal problem, and often at the individual patient level, it can be hard to see this as a priority. And I want to highlight to you that there is growing evidence of individual harms to patients with antibiotic overuse. So this figure in the middle is from a paper. It's quite old now, but it's a really great paper for demonstrating this principle. This was a before and after study where they were trying to improve, it's a US study, and they were trying to improve compliance with the American Thoracic Society guidelines for ventilator-associated pneumonia, which actually encouraged clinicians to use quite a lot of antibiotics, multiple agents. And as compliance improved, and therefore people getting more antibiotics, actually outcomes got worse. And so overall, it favored non-compliance with the intervention. And then there's another study here which shows, which is looking at the overuse of anti-anaerobic antibiotics. And with the overuse of anti-anaerobes, there is patients got more ventilator-associated pneumonia and had worse infection-free survival. So there's a reasonable amount of emerging evidence that there's individual harms to patients if you overtreat with antibiotics. So the Surviving Sepsis guidelines have been updated. They came out just about a month ago, and I've taken the recommendations related to antimicrobial use. And the main thing to highlight here is that these 3 recommendations are all very low or low quality evidence. So most relevant to this talk is this recommendation 39, where the Surviving Sepsis guidelines now say they recommend shorter over longer courses, which is great, but not hugely helpful, because what does shorter actually mean? Going back 2 iterations, they used to recommend 7 to 10 days, but since then they're just recommending shorter over longer. So we will explore what some of these shorter things might actually be. So could shorter courses treat sepsis? Well, the answer is yes, when we consider that the standard course length in the UK from recent trial evidence is about 8 days. So yes, you can go shorter, and there's evidence to support that. By what method? And I'm going to talk to you about biomarker-guided versus fixed course lengths. There's a really interesting question around how short can you actually go? And I'm going to show you some evidence specifically in sepsis, but also some infection-specific evidence, so trials conducted in pneumonia, for example, rather than sepsis as a syndrome, because it is those infection-specific evidence that has has informed the surviving sepsis guidelines. So biomarker durations. So this is, as you guys will know, clinicians in the room, what you'll see used in your hospitals are procalcitonin and C-reactive protein. And the evidence is almost entirely for procalcitonin. There's very little evidence for CRP, with the exception of one trial I'm going to show you in 1 minute. But I also want to highlight that we're talking about procalcitonin to guide duration and not initiation. So when this test is being used in your clinical setting, really think about when I'm requesting this test, why am I asking for it? Is it because I'm trying to make a decision about starting antibiotics, or am I trying to make a decision about stopping? Because the evidence around starting in sepsis is not supportive of PCT for sepsis. If you're talking about respiratory tract infections in A&E, yes, but not for sepsis. So we're talking about durations. So this is a recent meta-analysis which shows the summary conclusion from this is that the use of procalcitonin can reduce your duration by 2 days. I think one of the things to highlight across all of these studies is you can see that all of those green squares, they're all to the same side of the line. So there's a consistent signal across all of these trials that PCT can reduce your duration. And as I said, the summary of that is that it's about a 2-day reduction in your duration. So most of the trial evidence in this space has been from overseas, and so the HTA, the NHR, commissioned a UK trial. And this was conducted by Paul Dark, who I believe who's actually presenting later on today, to look at to develop evidence for a UK setting around procalcitonin, but also CRP. So this is one of the few trials that looks at CRP. This was a trial of about 2,000 patients, about 3,000 patients. It was a 3-arm trial, procalcitonin guided durations, CRP guided durations, and standard of care. The comparator was 28-day mortality and 28-day antibiotic use. So there was essentially an effectiveness signal and a safety signal. And the highlight from this is that there was a reduction in antibiotic durations with procalcitonin. So for the primary outcome, which hopefully you'll be able to see, the standard of care duration was 10 days, 11 days, and it was reduced to 10 days at 28 days with procalcitonin. But if you look into the secondary outcomes around the duration of antibiotics for the initial course length for sepsis, it was 1 day shorter with procalcitonin. So that clearly that 1 day difference persisted to the 28-day mark. And importantly, it was non-inferior for the safety measure of mortality. So this is UK data that supports the use of procalcitonin. Really importantly, it doesn't support the use of CRP to reduce antibiotic durations. One of the challenges with the procalcitonin trials is that clinician adherence to the procalcitonin recommendation is really poor. So the way this works is that you'll get a procalcitonin at baseline, and you will check the procalcitonin every single day, and if it drops by a certain percentage, there's a recommendation given to the clinician. So if it drops by 25%, there would be a recommendation to stop your antibiotics. If it drops by 50%, there will be a strong recommendation to stop your antibiotics. And so you need to kind of check it daily and then follow this algorithm to make a decision. And across most trials, you have about 50% adherence to the PCT algorithm, which I think is a really big limiter for the kind of effects that you're getting in the reduction of antibiotics. This was a recent trial done in pediatrics. It's a slightly different trial because they're not trying to reduce the overall duration of antibiotics, but they're trying to reduce the duration of the IV component of antibiotics. So this was in pediatrics. It's called the BATCH trial, pediatrics on IV antibiotics for bacterial infections in hospital. There was a stopping rule based on a fall in the PCT and then a switch to oral antibiotics. And the control was standard of care, which did include CRP. And the co-primary outcomes were duration of intravenous antibiotics, but also a safety measure. So the graph shows that there was no difference in the duration of IV antibiotics, but the bit I really want to highlight is this table here around adherence. So I'll just draw your attention to this kind of middle section of the graph, of the table, sorry. So PCT was considered at all clinical reviews in only 24% of study participants. So, you know, this is quite an extreme example of how lack of adherence to the intervention affects its ability to influence antibiotics. So, an alternative to having PCT-guided durations is, particularly considering this lack of adherence, is whether we can just say, well, you know, let's give fixed courses or tailor antibiotics to clinical response, but just reduce the duration without being guided by a biomarker. And there's quite a lot of trials in this space, and as I mentioned earlier, these are not trials in sepsis. These are trials in specific infections. So it's a pneumonia trial, it's a UTI trial, it's an intra-abdominal infection trial. But these are the trials that are informing that recommendation for the Surviving Sepsis Guidelines. So pneumonia is by far the biggest evidence base. There's quite a lot of trials in this space, and that has been largely adopted by the NICE guidance that does recommend quite short courses of around 5 days for pneumonia. Importantly, the evidence doesn't support duration of antibiotics for critically ill patients with sepsis with pneumonia, but many of you might recognize that in clinical practice, shorter courses are still given to those sicker patients with sepsis. And in my ICU, we'll often be giving patients with community-acquired pneumonia 5 days of antibiotics. So just to highlight a couple of trials. So this was a trial of, this is a Stop It trial. This was a trial of patients with complicated intra-abdominal infections. Again, it's a bit old now. But it included 518 patients. It actually was short of its sample size. Essentially, they ran out of money and had to stop. But the intervention was a 4-day. So patients who'd had either surgery or interventional radiology to get source control of their infection, once they had achieved source control, the intervention was a 4-day course of antibiotics versus the comparator, which was a maximum of 10 days, but guided by clinical response. And they had this composite primary outcome of surgical site infection, recurrent infection, or death. And essentially, there's no difference between the two groups. So there's a number of weaknesses with this trial, but this is the main trial in this space, and this does now inform international surgical guidelines. This is a recent trial in ventilator-associated pneumonia, which kind of extends the concept of fixed durations, but it's a bit more nuanced because actually there's an element of clinical response in here as well. So this was done in Asia, and it was patients in ICU with ventilator-associated pneumonia, and they had to achieve this fitness criteria, which was essentially that they were afebrile and they were off vasopressors. And then in the intervention group, once they met this criteria, if they were culture negative, they could have their antibiotics stopped as early as 3 days. If they were culture positive, as early as 5 days, but all antibiotics had to be stopped within 7 days. And then the control arm was at least 8 days. And they had a primary outcome of death or recurrence at 60 days. So the headline here is to say that in the intervention group, the durations the average duration was 6 days. In the comparator group, the average duration was 14 days. Now, many of you will recognise that that standard of care is considerably longer than what we do in the UK, and raises question. There's clear issues here around external generalisability. But really interesting concept of giving these particularly short courses, particularly considering the bugs that were grown in this study, a lot of bugs that would often have longer courses of antibiotics. And again, I just show you this plot at the bottom just to show that across all their analyses, it favours the intervention. I'm just going to stick with this graph on the bottom because it's just to inform the next slide I'm going to bring up. The way that these trials are designed often are what's called a non-inferiority trial. It's a shame that the pointer, I don't know if the pointer, it's not really working, it's a shame. So, but if you can see this 0 line, that would be to say that there's no difference. If you go over towards the, to your left, that favours the intervention. If you go over to the right, it favours the control arm. But the way you design these trials is you set a margin here, where you say, I'm going to let this outcome get worse, but so long as it doesn't cross this margin, I'm going to say that that's okay. Okay, important for the next slide. I hope that's clear. So there is an interesting question around what is the lower limit of antimicrobial use, because of course, you know, antimicrobial stewardship is really important. But antibiotics, we can't, you know, they've absolutely transformed human health. You know, they do serve quite an important role of treating infections. So, you know, if you keep on going lower and lower, there's going to come a point where the harms are going to start to increase. You know, infections are going to recur and they're going to slip through. This the study that's on your left is a trial called the SCOUT trial. This was done in pediatrics, pediatric urinary tract infections. It was a really well-designed trial because it was placebo-controlled. So in the standard of care, patients got 10 days of antibiotics, and in the control, it was 5 days of antibiotics and then 5 days of placebo, so it was blinded. And their primary outcome was treatment failure. And the treatment failure in the standard of care arm was only 0.6. But in the intervention, it was 4.2. So proportionally, that's quite a big increase in treatment failure. But they argue that actually, you know, there's a significant gain here in terms of reducing overall antimicrobial use. There's less burden on patients to take the drugs, and these are still relatively small numbers of treatment failures. This other study is a trial of antibiotic durations in patients with complicated appendicitis. So again, these patients have had source control, and then how many days of antibiotics do they get after their surgery? And it was 2 versus 5 days. And again, these are really small numbers, but they had a composite primary outcome of occurrence of intra-abdominal abscess, surgical site infection, or mortality. And then in this table, they break that composite into the individual components. And you can see that across all of those, the numbers are just slightly higher in the intervention. And they're very small numbers, but it just kind of highlights this point that there is going to be a kind of lower limit here where if you go too low, you're going to start to get some worse outcomes for some patients. And there's a really interesting really is, I guess it's a societal discussion around where does this kind of risk and benefit lie. Some people might have to bear some additional risk for an overall benefit to society around reducing AMR and reducing antimicrobial use. And I don't have an answer to that. So, emerging evidence in this space. There's a few trials going on. These are UK trials to keep an eye out for. The first trial is the septic trial, which is run by Tony Gordon from Imperial. It's a big trial. Originally was going to aim for about 3,000 patients. They've just had a sample size recalculation, so I'm not actually sure exactly what the sample size is going to be, but it has reduced. There are 3 interventions in that. The one that's relevant to this talk is that there is a procalcitonin and PCR diagnostic. So it's an algorithm where they're combining rapid molecular diagnostics with PCT. So that's one to look out for. That'll be a really interesting extension of the PCT literature. The middle one is the shorter trial. That is my trial, and it's a trial that's looking at whether we can give just a fixed course of antibiotics for patients with confirmed or suspected sepsis. So the fixed course length is a 5-day course compared to standard of care. Target sample size is 2,244 patients, and we're about halfway through, running in 50 ICUs, and the funder has just extended us to keep on going, so we'll be recruiting until 2027 and hopefully reporting in 2028. The last one, duration trial, might seem like a bit of a curveball, but this is a trial in women with urinary tract infections, so really not the sepsis space at all. But you know, as I've shown you already, a lot of the evidence that has informed the surviving sepsis guidelines isn't in sepsis. But it's a really interesting trial because a lot of trials, including my own, compares, you know, a single duration against standard of care. And of course, the obvious question is, how do you know that 5 days is better than 4 days, better than 6 days? So the durations is a really interesting design where they have multiple durations, which really should be able to kind of create a duration response curve where you're really kind of looking for a plateau effect of around clinical outcomes around the kind of optimum duration. So a really interesting trial to look out for. Great. So last slide. So patients with sepsis are, you know, they're a very high risk group of patients, and the pressure to initiate antibiotics is really quite high, and I think that's why durations is a really interesting area. You kind of accept that you're going to have to, if someone's critically ill, you're almost certainly going to start antibiotics, but how can you optimize stewardship by shortening the duration? There is now, you know, there is compelling evidence that procalcitonin reduces durations from 1 to 2 days in duration. But really think about this idea, think particularly around the VAP, regard VAP trial, around this response guided. When patients have responded to their antibiotics, clinically responded, what is the kind of shortest duration we can give after that period? And keep your eye out for the emerging evidence in this space. Thank you.